Thank you very much. Thank you, the organizers, and Lembit for the nice introductions of the PQ and also my involvement in this. I have quite a number of slides, but I will be skipping some of them in the interest of time and just trying to emphasize on some of the important areas. I've been asked to talk about the regulatory enforcement and the risk of counterfeit and substandard medicines in Africa, but of course in this case I'll be focusing mostly in Tanzania. Of course, for those who may not be knowing where Tanzania is, it's based in East Africa, the largest country, the most populous country in EAC, with many tourist attractions. For those who plan to see the animals, please, you're welcome to Tanzania. Thank you. Now, coming to medicines regulation in Tanzania, of course, this is governed by the Tanzania Food, Drugs and Cosmetics Act No. 1 of 2003, which provides for regulation of food, medicines, cosmetics, and medical devices. And this legislation also establishes the Tanzania Food and Drugs Authority, which is the national medicines regulatory agency under the Ministry of Health and Social Welfare, which also serves as an executive agency. This means it's semi-autonomous. The headquarters of TFDA is based in Dar es Salaam, with 5 zonal offices currently. Our plan is to have 7 zonal offices across the country. So we regulate the quality, safety, and effectiveness of food, medicines, cosmetics, and medical devices, of course, including vaccines and herbal medicines. That is our mission and vision. And of course, some of our key milestones is that we already have some key medicines regulatory systems in place, processes and procedures, which are also complying with current quality management systems. As mentioned by Lembit, our quality control laboratory is also WHO pre-qualified, and the food testing lab and microbiology laboratories are also accredited to ISO 17025. This is the headquarters of TFDA in Dar es Salaam. So now coming to the topic, counterfeit and substandard medicines. We all agree that medicines save lives and prevent diseases and epidemics only when they are efficacious, they are safe, of acceptable quality, and they are also rationally used. However, we have come across counterfeit and substandard medicines circulating alongside the approved quality medicines. We are also aware that counterfeiting of medicines is a serious global public health problem. It affects both developed and developing countries. Counterfeit medicines resemble silent murder because in cases where medicines are used for life-threatening diseases, for example, malaria, they may end up to losing life. It's a national problem with international dimensions because counterfeits have no borders. The impact of counterfeit on public health is quite obvious, and also on health systems. It leads to erosion of public confidence, to health professionals, and to national control agencies. On economy, of course, for sure, there will be loss of legitimate sale and tax, and also reduction on economic growth. Some challenges. This may not be unique to Tanzania. I'm sure they are also applicable to other countries. That in many cases we don't have adequate legal framework, and also the sanctions are quite inadequate. In many countries, particularly in Africa, we still have unharmonized regulatory systems with bordering countries where, of course, at the same time we have many porous borders. For example, in my own country, there are 9 countries bordering Tanzania, and a coastline of over 1,400 kilometers. So counterfeit goods can easily come into the country, although you have inspectors at the ports of entry. The number of inspectors many times are also not adequate. I was also asked to say something about challenges on supervision of overseas vis-a-vis local manufacturers as regulators. For sure, there's cost involved in conducting GMP inspections. In overseas countries, of course, they pay fees, but to do follow-up inspections are done actually normally between 3 and 5 years. At that interval, and of course, you don't know what happens in between. But there are also limited qualified GMP inspectors in many countries in Africa, including my own agency. Of course, we thank WHO for all the capacity building activities. There's also lack of harmonized GMP requirements and inspection procedures among NMRIs in importing and exporting countries. Sometimes a neighboring country may qualify a site, but another country goes and says, no, this does not meet the current GMP standards. So these are some of the challenges. I had some few slides on the examples of counterfeit cases that we've come across in Tanzania. We have records right from 1999 up to now, but I've picked only few, 5 cases that I would like to share with you. One of them is we had a case of counterfeit chloroquine in 2001. This was the first line anti-malaria in Tanzania at that time, where it was actually an expired chloroquine injection on the right. It was relabeled as quinine. So this was really a local counterfeiting which happened in the country at that time. We also have one recent very serious case of counterfeit methamphetamine anti-malarial, where when we tested, actually there was no completely, one of the active ingredients was absent, and this was pyrimethamine 25 milligrams was not there. The second active ingredient was actually available at the range of 0.4%, but the acceptance limit is between 90 and 110%. We had to suspend the whole product, and manufacturer had to do some changes to the packaging and then reintroduce it into the market. These are some of the photographs. You can see that you cannot distinguish them. They are very similar between the counterfeit and genuine. These are the immediate packaging. You could see one of them is counterfeit, one of them is genuine, but it's quite difficult for pharmacists to distinguish. This was 2 years ago, where we came across counterfeit Liafin. The genuine product is actually Liafin with E, and it is also one of the combinations of sulfamethoxypyrazine and the pyrimethamine, SP, as commonly said. Of course, the counterfeit one used a different active ingredient, and you could see the packaging between the two. They are very similar and very challenging for the inspectors and those who dispense medicines to distinguish between the two. And there was, this was also found on the market. This case, it was ibuprofen was being dispensed as erythromycin because they are similar in color. So they removed because erythromycin is expensive, so it was being sold as ibuprofen. This one was a serious case because it is antimalarial quinine on the label, but actually when we tested, it contained actually metronidazole. And this was being transported using as parcels between the regions. Of course, it was coming from neighboring countries, and we were able to confiscate this with the help of the police after serious follow-ups of this case. This is one of the operations we've been carrying out, operations with the police. This was one of the cases of substandard product that turned into black. This is paracetamol. Normally paracetamol is white in color, but because of the poor formulation and also not properly stored, it changed color to black. Just to conclude, I would like to say that combating counterfeit requires collaboration at national, regional, and international level. It requires political will and commitment, and also legal framework that clearly defines counterfeit medicines, and it recognizes it as a crime that is different and more serious than counterfeiting other kinds of goods. It also requires strong medicines regulatory framework backed by legislation. Last year, of course, the World Health Assembly also put up a new, what is called new member state mechanism, which is actually under the leadership of WHO. We hope this will now bring up a new international collaboration in fighting counterfeit and substandard products across the globe. Some efforts in Tanzania, I would like just to emphasize on the second bullet, implementation of a structured post-marketing surveillance program. Every year now we have certain products that we have identified that we are following up them on the market. We pick samples and test to see that they are complying with the current standards. The latest example we came across, for example, we were following up cloxacillin antibiotic, and we were able to establish that some of them, the level of active ingredient was actually below 50% of what is required, and this was proper after proper analysis in the lab. We also have a joint TFDA police and customs task force that carries out regular inspections, regular operations to identify and confiscate counterfeit medicines. Of course, in our current strategic plan, combating counterfeit and substandard medicines is one of our top priorities. We have also engaged some public education programs on public health implications of counterfeit and substandard medicines through TVs and radio programs. We also believe that the launch of the EAC Medicines Regulatory Harmonization project in March last year will actually, which is actually looking towards harmonized medicines regulatory systems in the East African community, will have a significant contribution in the fight against counterfeit medicines, because we will be looking at these things, all of us, at the same way. So we believe that once we are fully harmonized, we will be sharing experience and information, and we can also carry out joint operations as a bloc. So, in conclusion, I would like to say that counterfeit medicines is a real and serious public health problem that affects both developed and developing countries. The only way is to collaborate and cooperate among NMRIs and also among law enforcement agencies at national, regional, and international levels. And this is more important in Africa, where regulatory systems are still weak, or in some countries non-existent, which is also coupled with limited skilled human resources. So the only way is really to collaborate the government agencies and also the other stakeholders, including the manufacturers, distributors, and the health professionals. The new member state mechanism, which was established last year by the World Health Assembly, that now brings together international collaboration, cooperation, we also believe that will also bring the common understanding and joint efforts towards this challenge. Improved cooperation among law enforcement agencies. I've said this, I think this is also very important, especially at the borders. If you are not working together with the customs officials and the police and other law enforcement agencies, the National Regulatory Agency alone may not be able to combat this problem. Thank you.